Thank you, Dr. Nilanjana. I welcome all the delegates joined online. So, is Edis also there? Can anybody confirm?
We asked him to join, ma'am. I'll just correct. I'm calling him again.
Sure, fine. So I just apologize for the venue where I am right now. It's quite loud. I'm at the airport. So I just would like to quickly start with the presentation. I would like someone to just share the PPT, please.
Sure, ma'am.
If the formatting is a little off. So welcome everyone to this very important session on identification, intervention, and prevention of child abuse. So I'd like to go to the next slide, please. Next, please. So there are various kinds of abuse that's happening to the children, and they may be categorized as physical, emotional, sexual, mental, psychological, even cultural abuse and economical abuse. So as health professionals, we have to be aware of all these different types of abuse and the kind of mental and physical damage that it might lead to. Next. Next, please. So there are several serious consequences of a child who has gone through abuse of any kind. So as health professionals, we have to be very aware and taking to address this issue, where people from various disciplines have to come together, from psychiatry, pediatrics, obstetric and gynecology, even public health professionals, policymakers, advocates, even school institutions, educational institutions. Various kinds of people have to form a team. So my main topic is on community ownership, and in this, this multidisciplinary team will always be required. Next, please. Again, the impact of abuse on a child is not just on the child itself, it's also on the family and the next please, and the caregivers also, and the caregivers of such abused children. They also go through what is called as caregivers fatigue. Go to the next slide, please. So all these things I wanted to highlight, because when we go to design an intervention for addressing child sexual abuse, we have to take into consideration the training requirement for a psychologist with the mental preparedness they should have to address a situation. Even health professionals and even community members, they have to be aware of all these situations and mental preparedness they should have, and the required training to deal with such cases. Next, please. So, definition of child sexual abuse. The WHO has defined child sexual abuse as the involvement of a child in sexual activity that he or she does not fully comprehend and is unable to give informed consent to, or for which the child is not developmentally prepared or cannot give consent, or that violates the law or social taboos of society. So we as health professionals, we have to be aware about the legal provisions, what are the legal aspects that we have to think about while medically or legally help a child. Next, please. So this is a very alarming situation. The recent NCRB data shows that there is a rise in crime rates against children, and most of it is related to sexual offenses as per the registered POCSO cases. Next, please. So this is a chart showing the rise in the trend, which is very alarming. So this is the latest data which I have tried to gather. There is a 179% rise in the crime rates against children between 2013 to 2022 in India. Next. Next, please. Why are the children vulnerable? That is another question we have to think about, because we have to then identify which are the type of children who are have higher influences, which some of them are known and some of them have to be probably researched further and identified. The attitude of family, community, social educational institutes, and even health institutions towards this very important issue is also to be looked at. Because probably of a lack of training and exposure, inexperience, they do not feel confident in dealing with such cases. So you can see the total crime rates increase from 33.6% in 2021 to 36.6 in 2022. And I have just tried to highlight Assam has a higher percentage reporting for child labor and also child marriage, 50% rise in child marriage in Assam as well. Again, 32% rise in the cybercrime rate against children is also identified. Next, please. So these are some of the situations when a child may be highly vulnerable. When there is an unaccompanied child, single parent home, a broken home, child in foster care, children in foster care, adopted children, physically or mentally handicapped children, children living in poverty, socially isolated and outcast families, parents with mental illness, and parents with alcohol and drug dependency. So these are the various situations in the list, like in the minimum I could identify. There may be more also. So we need to research further. Next, please. Next, please. So issues with the health system. So as I said, community ownership will not happen without an enabling environment. And enabling environment for the health system will be that the healthcare worker has to be adequately trained to recognize possible signs of child abuse at an early stage. Lack of training in investigating and or handling cases sensitively and safely, including issues of confidentiality, and again, inability to respond to the disclosure of an abuse. Even if a patient comes and says he's been abused, he or she has been abused, whether the doctor knows what to do next. So these are the things which we have to discuss in our, ensuing presentations by the different speakers. Next, please. Again, as I said, training manpower will be very important, not just of the medical health professionals, but of the various other disciplines. So sexual abuse awareness training is the key to equipping staff members and volunteers to better understand the risk of child sexual abuse. So this particular aspect has to be dealt in order to have community empowerment. And next, please. So I would like to classify community ownership of victims into two types, like for prevention, how to prevent it, and if it has already happened, then how to respond, how to recognize and report such cases. So the concept of community ownership is that this method is based on the understanding that sustainable change in child safety and well-being must come from within the community rather than being imposed from outside. Next, please. So building community ownership, these are a few points I have tried to highlight over here. So we will require supportive environment, and then people who those who want to proactively report any suspect child abuse cases, they have to be also supported. They have to receive the necessary support. They should not be threatened or ridiculed, or they should not feel unheard. Next, please. Next, please. So we have to address the barriers in building community ownership. So there should be there is a lack in transparency in the investigation process. There is a post-reporting. might not to go ahead with the reporting. Next, please. Next, please. Am I audible? So this is something which I found out, which they have applied elsewhere, like 5 intervention for child safety. We have to provide sexual abuse awareness training, skillful screening, policies and procedures to protect the child. We have to do background checks of people before employing them in schools or as caregivers for children, and then the process of monitoring and oversight. Next, please. Have I exceeded my timing? Please let me know. Now, to address the incidents of sexual abuse or child abuse, we need to have proper data, even for coming up with policies and programs. But due to lack of those in 18 to 29 years, when surveyed, they had experienced sexual violence before the age of 18. Next, please. Next, please. Yeah, these are some reasons why the families do not like to report the cases. Excuse me. Hello. Am I audible? Am I audible?
Yes, you are audible.
Yes, ma'am.
I'm
You're
so
audible.
sorry. I'm so sorry. I'm just trying to board the next slide right now. And again, there are issues with the implementation of the law. Again, since most of us do not know what is the provision under the law to protect, or what rights we are given to report and record, or even provide support to such children. But because of that, again, there is another barrier in developing community ownership. So we have to probably, Dr. Nilanjan is a part of our telemedicine. So I would definitely request her to take up this issue in our telemedicine programs. Next, please. So children are a priority. We say the child is the father of a man. So that means the kind of upbringing we are going to give to our children, the kind of childhood they are going to experience, that is what will determine the future course of humanity. So, under the Sustainable Development Goal number 5, gender equality is one of the main issues. We see that child marriages remain a potential threat in achieving this goal of the Sustainable Development Goal number 5. Next slide, please. Next slide, please. So this is a chart showing a little positive image of the declining rate of child marriages over time, and it should continue further. We should see more progress in this aspect. Next, please. Next, please. So under the Sustainable Development Goal number 5, there are 9 targets which addresses this issue of child safety, rights of the child, and development of the child. So we have to look into it. What is it that the policy? What is the policy of the government, of the World Health bodies or organizations which work for this cause? So we have to come together and ensure that we achieve these goals. Next, please. Next, please. So this is one of the helpline, which I think every one of us should know. And in future, if we are planning to establish a child support center in AIIMS Guwahati, we have to develop such a helpline for any distress call, and somebody should be there to report, to receive 24/7. So this will be kind of something which you have to develop. Next, please. So I have almost come to the end of my slide, and let us hope that all of us today we come with some ideas which we can work on, and start, helping these children who really desperately need us. And this is with this, I would like to end my presentation. Thank you all for your patient listening. If anybody has any question, I'd like to answer now. Nilanjana, please.
Okay, thank you, ma'am, for the presentation. Despite your busy schedule, it was really nice, and we
I'm
look
so
forward
sorry.
to
I
our great
apologize
seminar.
to
We'll connect
everybody
with you,
for this
ma'am.
inconvenience.
No, ma'am. Thank you so much. Thank you so much.
So
Okay.
I really thank you for taking this initiative, and I hope the rest of the presentation is hopeful. But sadly, I won't be able to join you since I'll be
Sure,
on
ma'am.
my
We'll have the
flight.
recordings. We'll have the recordings. We'll share, ma'am. Thank you, ma'am.
Thank you so much.
Thank you,
Okay,
ma'am.
I'm signing out. Thank you,
Yeah.
everyone.
Thank you, ma'am. Okay. So with this, we move to the next part of the webinar, and that is our keynote address. We'll be waiting for our director, sir, to give the keynote address. Then but we think we are not able to connect to sir. Sir is out of station. So after that, we can move on to our first speaker, Dr. What is the time, ma'am? We're going to Dr. Preeti Lekha Deka, ma'am. Ma'am, are you there? Preeti Lekha Deka, ma'am. She just joined. She just told me she just joined. Preeti Lekha Deka, ma'am. Preeti Lekha Deka, ma'am, are you there? She just said that she will join. Then we can move on. Then we can move on with our next presentation. Hello. Hello. I would request ClearNet to have the faculty list. Ma'am, the audio, please switch on the audio part of it. Zoom link को click कीजिए, ma'am. Okay, so Rituparna ma'am.
Yes, ma'am.
Hello, Rituparna ma'am.
Yes, ma'am. Am I
Are you
audible?
there?
Yes, ma'am, I'm there.
So we can request Samarendra sir to take over this session till we connect to Pritilekha Deka ma'am. She is having some issues with connecting. Okay.
Okay,
So I'll
ma'am.
just request Samarendra sir to take over the session I'm clearing this problem with Pritilekha Deka ma'am. Her Zoom link is not, I think, is not working something. Okay, I'll just see to it. Okay.
Okay, so with all your permission, then I'm presenting this presentation now.
हाँ, Samarendra sir का presentation है. हाँ. Hello. Hello. Hello.
Respected Executive Director Sir of AIIMS Guwahati. Can you hear me all?
Yes, sir, you are pretty much audible,
Okay.
sir.
Respected Executive Director Sir of AIIMS Guwahati, all the esteemed speakers and their participants. Good morning, everyone. So my talk is on way ahead, opening of one-stop resource center and capacity building of healthcare professionals in relation to child abuse cases. Move on to next slide. So the previous speakers have already spoken about the problem of child abuse, the magnitude of the problem, and what is the current status all over the world of child abuse cases. So World Health Organization has already defines child abuse as all forms of physical and or emotional ill treatment, sexual abuse, neglect, or negligent treatment or commercial or other exploitation resulting in actual or potential harm to the child's health, survival, development, or dignity in the context of a relationship of responsibility, trust, or power. So World Health Organization has defined child abuse as a silent epidemic. It has 4 different forms: physical abuse, sexual abuse, emotional abuse, and neglect. Move on to the next slides. If we see the statistics, World Health Organization in 2022 states that nearly 3 in 4 children, or 300 million children aged 2 and or psychological violence at the hands of parents and caregivers. In India, according to a recent study conducted by the National Commission for Protection of Child Right, NCPCR, has found that nearly 55% of children in India experience some kind of abuse. Next slide, please. Talking about the challenges in relation to child abuse cases, the most important problem is rising incidence. We can see it has different factors which play a role for rising incidence of child abuse cases. Their socio-cultural, socio-economic, familial factors are there. And the cases which we get in the hospital, they are only the tip of the iceberg. Majority chunk of the cases are still not getting reported. Then second major problem is less reporting of child abuse cases. There is ignorance and lack of awareness on the part of the caretaker or guardian or parents. The parents may themselves involve in child abuse, or they may not involve in child abuse, but irrespective of the status, they are ignorant of the fact that it is an offense. So there is ignorance on their part, and they used to deny it. They think that it is a common approach to discipline children, to control their behavior. So that has become a common practice among them. And because of that, many a times they don't come for any any reporting. And there's discrimination and repercussion if they come for reporting in the hospital. If you go to the police station complaining about all this, then there is a fear of retaliation, and there is also fear of hello. Yeah. So please move on to previous slide. Okay. So the problem is failure to detect the cases of child abuse in the hospital as well as in the periphery by the healthcare professionals. It is said that atypical presentation of child abuse is commoner than typical presentation of child abuse. So we have to think of it when we get a pediatric case or child coming for any other presentation with any symptoms. We should always think of child abuse. If we think of child abuse, then we'll be able to find it out. Otherwise, it is very difficult to detect child abuse cases in hospital as well as in periphery, the remote, in the other centers also. The third important factor is lack of comprehensive care. As of now, we don't have any specific intervention which is in place to address the problem of child abuse. We don't have, we have specific intervention or specific medical care for the child sexual abuse cases and other gender violence cases, but we don't have any specific intervention or comprehensive care in place to deliver service to the cases of child abuse. So that is the one thing which we should really work on it. Please, next slide. Next slide, please. Okay. So talking about the legal provisions in India, we have so many laws and legal provisions which are in force to protect child from abuse. For example, we have Section 75, which provides punishment for cruelty to a child. We have Section 76, which provides punishment for abetment of suicide of a child. We have Section 317, that is penal provisions for abandonment of child below the age of 12 years. We have Section 366A, Section 372. We have Prohibition of Child Marriage Act 2006, the Immoral Traffic Act 1987, Child Labor Prohibition and Regulation Act 1986, Juvenile Justice Care and Protection of Children Act 2015, and most importantly, we have the POCSO Act, which has been enforced to protect children from sexual offense, more precisely sexual assault, sexual harassment, and pornography, to protect children from all these criminal offenses. Next slide, please. So this one-stop center OSC scheme, this is one novel approach which can, if instituted or implemented, can be of great help to address cases of child abuse cases. We have this scheme in force to provide comprehensive care to all cases of gender violence, gender-based violence. But as of now, we don't have any this kind of approach to address cases of child abuse. So this approach, if we can implement it, has two major advantages. One advantage, the first advantage is providing comprehensive, hassle-free medical care under a single roof, which includes medical aid, police assistance, legal aid, and case management, psychosocial counseling, and temporary shelter. And second important benefit of this scheme would be it will enhance reporting. The cases will come to the OSC and those cases can be reported. So we can take all those individuals under 18 years of age with alleged history of abuse to come for this OSC if we have this OSC scheme in place to address the issues of child abuse. Next slide, please. Role of healthcare provider. Well, healthcare provider has tremendous role to play in relation to addressing the problem of child abuse. Number one is they can identify the problem during examination in the hospital or in clinic or in the periphery or in the remote areas in other health centers. They can find it out whether someone is suffering from child abuse or not. Second thing is when they get this type of cases, they can inform the law enforcement agency and they can refer those cases to the OSC if one-stop center is in place for this kind of cases. Then they can be an important part of the medical team, which would provide comprehensive medical care to the victim or survivor of child abuse. Then lastly, they can also involve in this protective preventive measure to counter the menace of child abuse by organizing a community awareness program with other stakeholders. Next slide, please. So regarding training and capacity building, this first thing which we should think which should be implementing is to having an SOP, that is standard operating procedure, institutional standard operating procedure, which will be framed in line of the state government SOP as per the Ministry of Women and Child Development for setting up of one-stop resource center. That is the first step we should have. Then the second one is infrastructural development. We should have all the facilities required to deliver the service related to OSC. Then there should be periodical training of the healthcare workers, including doctors, by the resource faculties coming from those centers who have been actively involved in providing inform about the availability of if it ever comes to materialized. Next slide, please. So this one key strategy in relation to setting up of one-stop center is if we can introduce a mechanism where OSC would become the first point of contact for all alleged cases of child abuse instead of police station. So if we can do it, it will have dual advantages. Number one advantages is it will enhance reporting of cases of child abuse because many a time the parents or the caretakers or legal guardian, they are scared of going to the police station. They fear discrimination, they fear legal hassles, so they don't go to the police station complaining about child abuse. So if we can make OSC as the first point of contact, definitely it would help increasing reporting of child abuse cases. And number two is swift delivery of comprehensive medical care to all the victim or survivor of child abuse. So this will be one key strategy if we can implement the OSC scheme for attending cases of child abuse. Next slide, please. So this is all from my side in relation to setting up of one-stop resource center, and capacity building for healthcare professionals. Thank you all.
Thank you so much. Now, thank you so much, Dr. Samarendra. Now for the presentation. Now we will request Dr. Santosh sir to carry on with the next session. Thank you, sir.
Ma'am, sorry to interrupt, but we have got a question in the question answers box for Dr.
We will take
Samarendra.
the question answers at the last.
Okay, ma'am. Sorry.
Okay, so we will request Dr. Santosh sir to carry on with the presentation. Welcome, Dr. Santosh sir. He is additional professor, Department of Community and Family Medicine, AIIMS Rishikesh, working with much passion in field of community and family medicine, and I request him to take over the session. Thank you, sir. Despite a busy schedule, for agreeing to be a part of it.
Thank you, Dr. Nilanjana. Am I, my slides are visible?
Yes, sir.
Okay, my voice is audible?
Sure, sir. Sure, sir.
Okay, thank you. Thank you very much. First of all, I would be very much grateful to the director and head of the Department Community and Family Medicine, Dr. Nilanjana, also to have me at this wonderful platform and to take this great initiative, which is the need of hour. Ladies and gentlemen, that we have to learn how to take the initiative, and I congratulate the Department of Community and Family Medicine, Guwahati, that AIIMS Guwahati, that they have taken this wonderful initiative where we have to act. My topic is the role of primary care and family medicine in child abuse identification, intervention, and prevention. First, I would like to draw your attention. Would you be able to see these are pictures, 3 of the pictures? You know, what we are inclined for about this presentation and about this topic, what is very important and crucial we are going to learn, that is assess. We have to assess. Second, assist. And third one, the advocacy. Is all right. Then you can see the 3 pictures, and the 3 pictures are not same. What is the difference that we have to assess? Is all right. So that's the case number 1. I'm just going through that. A 15-year-old girl brought by her parent to my OPD with the complaint of aggressive behavior, loss of appetite, and on F, abdominal pain, irritability, short temper, and headache for last 6 months. They have undergone through list of investigation. Her mother was asking me, Doctor, please go for the ultrasound. Her father was asking me to please go for the CT scan. They are insisting. What is the role of a primary care physician? What is the role of a family medicine expert in this context? You know, when you see the picture, it looks like, ladies and gentlemen, it's my humble request to please pay attention, all the primary care physician, all the doctors. When you see the things, even for the parents or any person who are listening to me, the picture, what you see, that may not be the real picture sometime. That's why I'm saying that we have to explore and we have to assess. The picture may be like this. The smiling face does not mean that the person is smiling from inside. It's all right. There may be some gap, and that gap has to be bridged. And because of this poor gap, this type of incidents are coming out. It's all right. That's not even the India, even the US. Affluent countries are facing the child abuse, right? The child abuse is not even restricted to the child, toddler. It's start from child and goes to the adolescent. It's really a great public health concern. You know, the children up to 5 years are more vulnerable since a relationship. You know, what is that? When I interview that child, what mention I have in this question, that the father and mother both are very much concerned. But daughter is having the smiling face in front of me. I have explored the child. I have asked the parents to be seated in one side. When I explore the child, then what the child came out, you know, I'm just coming to the next picture. The 15-year-old child, I've talked to her, can I talk to you? The child was very, very, very happy. Yes, I would like to talk to you. Would you like to talk to me alone? So what she said? She smiled. Yes, because nobody would have asked her before that. When I've asked the child, what child admitted to me, you know, she told me, my all illness, my parents are responsible. My parents are responsible. I told her, why are you saying like that? Are you having a physical abuse by them? Do you have any incidents of physical abuse? She said no. Do you have any reprimandation from the family? She said no. Then I told, what happened? She told me that their extra care, their unexpected, ideas from me, their expectations from me, their restriction for me become a suffocation. When the boundary of love and care crosses, it's become suffocation, ladies and gentlemen. We have to keep in mind. The 15-year-old girl, she came out that she's feeling suffocated in the home because she's getting the extra care. She's getting all the instruction from the family every time. Every time, what she is doing, what she is eating, what she is doing with the mobile, where she is going. I don't want this all silly instruction and silly care from my family. I'm fed up of this. Ladies and gentlemen, we have to understand, that this extra care, even for the age group of 1 to 5 years, is very much fragile and sensitive. Any of the activity is being taken at the family level, community level, society level, is having a very intense influence on the cognition level of the child. That if there is any abuse in the society anywhere, if the child is having abuse, and one thing I would like to make you very clear, parents become very intelligent right now. I think it is my personal experience that the physical abuse is very less, while the emotional abuse is coming up very well. Even if the physical abuse is there, the child not able to come out with to see this is the physical abuse and this is the injury which is given by my mother, the child will not come out with this notion. And you have to assess and explore the child from all the dimensions of health. So that cognitive, motor, and language delay are seen secondary to the reason. You can see that the baby shows delayed development and excessive cry if they are having any type of emotional, physical, psychological neglect, any type of abuse during the childhood. And 1 to 5 years of age, ladies and gentlemen, is very crucial and very sensitive. Toddlers show apathetic behavior and fearfulness and violence. I'm talking about the adolescent, that the questions what I have mentioned, the patient came to me with the diagnosis that is the oppositional deficient disorder, aggressive behavior. Who is responsible for that? The child is responsible? No. The society is responsible? No. Who is responsible? You, me. The second case I'm coming to you, that I don't have a good bonding with my father. In fact, I don't miss him. Again, a 9-year-old girl came to my OPD and frequently going to the community, and he doesn't love me. He's loving more my younger brother. Could you please convince my parent to put me in a hostel, please? Have you ever thought, as a parent, as a brother, as a sibling, could you think any of the 9-year-old girl is saying, could you please convince my parents to put me in a hostel? All the primary care physician, all the doctors who's listening me, this is the time, this is the alert, this is the sign when you have to catch it. And you have to think over, this is the time we have to explore the abuse. It is abuse in the family. The baby is saying that put me in the hospital. In a hostel. A strong predictor of one thing is child abuse potential. The child abuse potential inventory is being scored and used to assess the potential of the family, how they are using this one, so that the intimate partner violence and the post-traumatic stress given by the family, given by the community, given by the society, peers, anyhow, it is coming up in the later life. So when I have interacted with their family, so what they say, how many children do you have? I have 2 children. The younger one is 4 years. Elder one is 9 years. What is the problem? No problem. We are caring my child very much. I love my child very much. I'm asking her to read it. How you are asking? This is parenting. Ladies and gentlemen, parenting is an art. Sometimes if I'm asking, I'm slapping my daughter. Suppose I'm slapping my daughter for her well-being, for not to indulge in a mobile, in a screen time, or any of the ill activity or any of the misbehavior. Is it a way to slap? Or how to tackle with these issues if she is doing any type of misactivity or misbehavior? Might be the once the baby was bitten by his father, not by mother. The baby she's having that impact on her cognition level that I have always been lectured by my father. Father may be doctors like you and me. The lecturing is also being a stressful situation. That's all the parameters. That's what I'm saying. That what is responsible? That is the development. That is the developmental ecological model where the parents, family, socio-demographic, parent-child interactions. Sometimes what we see, in my time, I used to study in a candle. There was no light. For God's sake, that was your responsibility. That was my responsibility, or that was my time now. Now, why you are unnecessarily imposing? Why we are remembering your child that I used to study in a light, in a dark room, that all things. Right now, there is electricity. Now there is a phone. The situation has entirely changed. The ecology has entirely changed. The interaction threshold, everything is changed. So better do not give lots of instruction to the children, because this model works. That is called the child abuse potential is measured by the psychological development, immediate context in the home. What type of family size is there? How are we neglecting the child? Are we there is a maltreatment in the child in the family, and broader context is the neighborhood, society, community, peers. That the parenting is the art. If you have to learn, I'll tell my story. When I even raise my voice to my children, they tears up. They started tearing. And when my wife, their mother, even they are beating with the sticks, there is no effect. They are not tearing. Even they are becoming more loving with the wife. With their mothers. I told my wife, what is that thing, yeah? When I even raising my voice for them, they started tearing. My wife told me, it's all about bonding. It's all about bonding, that are we able to make that bond? I'm not saying don't reprimand your child. I'm not saying that you should not be strict and authoritative for your child. You be authoritative, you be strict. Don't pamper them. Don't make them fragile. Be strict for your child, but the art of being strict you have to learn, ladies and gentlemen. You have to learn, because the scenario is changed, context is changed. You have to learn. I am also learning. Please join me. Physical punishment could be used to the discipline, but if you are doing the physical punishment, then what about your bonding? Are you able to make that level of that category or that level of bonding with your child? Right? So that the parental sometime, the punishment what you are giving your child, is it because of your frustration, because of your disharmony, because of your mental illness, or because of your anxiety? It will be definitely reflect, ladies and gentlemen. Neglect is one of the act of omission. Neglect means if you are neglecting the psychological need of your child, if you are neglecting the physiological need of your child, it will create the impact that will lead to a very, very great abuse, and it will be reflecting later in the life. Ladies and gentlemen, we have to understand that negligence at any aspect, physical, social, and it's his or her peer pressure, we have to look into. That's very important. Though it has been said that neglect is the rarest abuse, I think if you start neglecting your child from today, it's becoming the abuse in the future. That's when we are treating with a child, I'm not talking about the individual, that we are becoming very passionate, and we are becoming very fascinating. That when I was a child, I used to be like that. When you see into the mirror now, you see that my child should be this. I used to study 10 hours. My child used to study 20 hours. Or I have started my preparation for medical when I was in 6th, but my child is not preparing, even if he or she is in the 8th or 10th. So the picture like that. And when we are fascinating our pictures and thoughts or notion like this, that's the coming thoughts about my child, about other child is like this. That's wonderful. My child, I'll guide because I'm a doctor, because I'm in that position. I can guide, I can treat my child according to my knowledge. But what happens when you started saying that the baby context from your side, always we see being a doctor, if you want to be a good doctor, put your shoes in the leg, put your leg in the shoes of patient. In the same time, if you put your leg in the shoes of your baby or your children, then you assess the situation is more turmoil in that area, in that side, in that context. You know, when your patient is at the tertiary care, you see the fragment of the apple. When the child is coming to me that I'm having a headache. A 15-year child coming to me, I'm having a headache. That is the time. That's I have mentioned in my initial.
Sir,
Okay. Am I over? Okay.
sir, thank you.
I'll take only 1 minute, right? 1 minute. So that the fragment of the apple is being treated and is being judged by us. Please do not be judgmental for any of the child till the age of adolescent, because the entire apple we have to see that's related with the biological, social, and psychological well-being. So solution, I'm just coming, I'll take only 1 minute. That the solution, what we have to learn, learn to connect, learn to collaborate, and learn to take the risk. That is the challenges. If you'll take it, definitely we can reform, we can start taking a new initiative, a new action in the society. The collaboration with the organization, collaboration with the NGO, government, and self-help group. If the child is coming, if I think as a doctor, the child is being abused by the parent, what can I do? Can I directly complain to the police? No. A lot of studies has been done that the primary care physician are getting this type of problem, but we are not able to do anything. So we have to connect with the people. How? I'm trying to connect with my UAJOS program. I'm going to the schools, lots of schools, and I'm talking with the children. I'm interacting with them. This could be one of the way how we can assess the people over there. And this is my UAJOS program and youth wellness program is going on in medical colleges, in universities, in intermediate school also, where I'm interacting with a child and getting their emotional level and getting their problem, their hassles, they are sharing with me. And after that, what we have to interact with the parents. This is my community holistic health and wellness program through Mahila Arogya Samiti in the slums, where we can tell the patient, we can tell the people regarding what? Regarding the parenting, regarding the assessment, how they are assessing their children. Now, this is if you start doing, connect with the family, connect with the people, then you will come to know what is the real scenario. Only statistics is not going to be effect. And in last, what we have created, I have created a group of senior citizens, ladies and gentlemen. These senior citizens are going to talk to the parents. If you will talk, are you abusing your child? Maybe they might be offended. If the senior citizen group are going over there, they can make them understand. And this is my last slide. If you will connect, collaborate a day when the government will come and government will listen to you and will work on your concept and work on your initiative. Thank you very much, ladies and gentlemen, for patience hearing. Thank you.
Thank you, sir. That was really nice and such an excellent deliberation. It was very informative and very helpful also. We will look forward to connect to you more, and we will, sir, really look forward to have some workshops with you. The Yuva Josh program was really nice. We will look forward to have it in our place also with your help and support. With this, thank you, sir. With this, and despite a busy schedule, you prepared your part. That was really nice. I mean, we are really thankful to you. After this, we move on to Dr. Raman Kumar, sir, who is here to present with us the next session. He is an eminent physician. We all know him, and we invite Dr. Raman Kumar, sir, for the next presentation. Dr. Raman Kumar, sir, are you there, sir? Then I think Dr. Raman Kumar sir was said that he had to leave to clinic. So I think we'll connect with him after 10 minutes. May I have Preeti Lekha Deka ma'am on board?
Am I audible now? Am I audible?
Ma'am, you are audible, but your voice is echoing, ma'am. Are you connected with two devices with close proximity, ma'am?
She's here. She's ACS and as this part of busy schedule, she is with us. Dr. Subhajit, sir, ma'am, will be introducing ma'am, and then we'll start with the presentation.
Good morning, all.
Dr. Preeti Lekha, ma'am, are you connected with two devices simultaneously?
Yes, I'm just leaving one.
Yes, ma'am. So unless you leave, the echo will take place, ma'am.
Am I audible now?
Yes, ma'am, perfectly.
Good morning, all, and respected director and all the respected speakers today. I at the outset congratulate All India Institute of Medical Science, Guwahati, Assam, for conducting such a wonderful webinar topic, which is very, very relevant for all of us. And I think we are, as hearing the other speakers also, I must say that we are all conscious in our roles, and we know that child are the most vulnerable part and section of the society, not only because uh, they are, for different reasons. We must say it is not that the child that we have it's in our home are not vulnerable. It's we have to take in consideration our children whom we raise, and we think that nothing can happen to them. It is not like that. And it is also about the society where lots of cases, as in the earlier presentation was shown, that the crime against child has been increasing. Now, we as from the Women Child Development Department, the State Child Protection Society, there are a lot of mechanisms that are working for prevention of child abuse. I will not take much time because I have been given 6 minutes, and therefore I will just stick to some of the important points that and the aspect that we are looking into. I would just like to mention the acts that basically we are working under. Mainly the Indian Constitution, yes, of course, and with that we have the Juvenile Justice Care and Protection Act, the Child Marriage Prohibition Act, the Protection of Child from Sexual Abuse, the POXO Act, Immoral Trafficking Act, and the Prohibition of Child Labor. These are the basic acts that gives us the roadmap of how to work for protection of child. And under the Juvenile Justice Act, we have the Mission Bachaya, which is the roadmap to prioritize protection of child and to reach the overall development of the child. Mainly, we work on rehabilitation of the children. So the act itself says that the child, who is a child? A child is a person who has not completed 18 years of age. So this is what we have to look at, and it is our aim that those children who are out in that society or in that environment where they are not in the safety net, we should try to bring them in the safety net. In doing so, we have 3-4 mechanisms. We have under the Juvenile Justice Care and Protection Act, we have the State Child Protection Society, which at the state level works for the protection mechanism. And then under the State Child Protection Society, we have the different district child protection units. We have it functional in all over the state of Assam. And under the Juvenile Justice Act, we categorize the children into 2 parts, basically the children in need of care and protection and children who comes in conflict with law. Now, for the children who are in need of care and protection are those children who for many reasons, for example, for many reasons come into, they need care and protection, maybe because they had some family background where, their parents have expired, or they have, while, they are into some kind of, they are missing, or any kind of abuse has happened to them like that. So those children are placed before the child welfare committees, the CWCs, which are again operational in all the districts in the state of Assam. The under the CWC, after the production, we have one chairperson and 4 members in the child welfare committees, and the committees then recommend to child, they have their medical and everything done, and counseling part is also there, and the children's homes are there, which we call as a whole are the child care institutions. So these child care institutions, we have the children homes, we have various children homes at different centers. We have adoption centers under the state agency, I mean resource agency, the adoption resource agency. So under that we have the state adoption agencies also. And the children who comes into conflict with law for various reasons, they are placed before the Juvenile Justice Board. Again, the Juvenile Justice Board is, we have the principal magistrate there and 2 social workers who are acting as members in the Juvenile Justice Board, and such children are placed at the observation homes. Now, various kind of attention is given in the children homes, starting from their basic needs like shelter and health facilities. And apart from that, basically looked at the education, because as we are all aware that the Right to Education Act is such an important act that we should not leave any students, any children, we should bring every children into the net of education. So we provide, the children homes provide basically food, education, skill development, health, and different type of training programs. And also because these children comes from such an environment that they might be undergoing different mental pressures and different changes. So therefore we have counselors who try to give counselings. And for the adoption centers also, those parents who are the the PAPs, like who are prospective parents, the counseling is given to them also. The counseling is a part which will not only help in the child to be mentally to grow, but also will help to overcome the conditions that they have come through. And we have very good results also. AIIMS in this platform would like to share that the children, some of the students in the children home have really done in their examinations in HSLC and HS, and look forward in doing something very positive in life. But as the topic is given to me, which says burden of cases, now as government, we cannot treat any case as burden. But I understand what I have been asked to talk about are the difficult cases, which we come across. Now, the most difficult part which I have through my being part of this child protection mechanism have come across is just to social stigma. First, I would like to say that restoration part is the most difficult part when we come across child who are abused, not only mentally, but emotionally, physically, the POXO victims, and also children who are trafficked and child labor victims also. So the even for simple, like if we take nowadays that there are elopement cases also, where as one of the earlier speaker had talked about the consent part. The consent part, as we all know, is very, very difficult, where a girl feels or a boy feels that they are in love and then they elope, but they don't feel the consequences that comes aftermath of those things. So a girl, when a girl child, especially I'm talking about among the children, I feel that the girl child is more vulnerable because of the biological conditions that a girl child comes across through her physical changes that she goes across. We have in the recent times we have seen that all type of girl children have been vulnerable from abuse. it is not that a girl who has reached the age of adolescent is only a victim. We have seen that small, 1 year, 5 year, 4 years, a year, I mean, the age is not a bar when we see about the abuse cases. We have seen that, there are girls who gets pregnant, we have minor pregnancy, we have minor victims again giving birth to minors, I mean babies. So both the mother and the child is vulnerable. So this whole part that we look into the care, protection, rehabilitation, restoration, the mainstreaming to the society, it gets very difficult because of the social stigma that is given. So I feel that it is high time that this kind of webinars should be held more, and we should understand the child psychology, and the society should come into, we should try to create such awareness where the stigma against the child, against the victim is not there, where the mainstreaming is, we can be done. Then we have uh, uh, victims, or we have children who has HIV or AIDS. Because we have so many doctors today, I would like to emphasize this, that there are a lot of convergence required between between the health department and while looking into child abuse cases, because starting from medical examination to ossification, the determination of age, and then how to help the HIV/AIDS positive cases, to the substance abuse cases where many children have come into drug abuse and drug addictions problem. So these are the areas, gray areas, where we have to work more, and I think more collaboration is required. Still, there are, we have seen in the whole mechanism that there are still confusion of how to go about, or how to collect the reports, how to inform. So these all can be helped when we have more of convergence, and more we can collaborate. We can have more training where we can have a similar platform where representatives from government, from the health department, doctors can be there together, and we can have more coordination in helping these cases. So apart from this, I think one of the speaker had talked about the child helpline number. We have, yes, the 1098. We have now we have integrated with the women helpline also, and we have the WCD control room in the Beltola, which is which is opposite to the Lucky Mandir. The control room is there, and the arrangement for the district at district level, we have already done. So 1098 is very much functional, and I'm glad to inform that it is already integrated with the emergency response support system, the ERS. That is
Share
one.
screen ya. So, oh yeah, yeah,
These are the areas that I wanted to talk about. And also, I would like to inform that to help a child mentally, the special codes for especially the POXO victims, all the codes have been made child-friendly environment, and there are many areas where we have tried that the district child protection office also are trying to be made child-friendly, having a child-friendly environment, so that when a victim comes, they don't feel that we are presenting in a court, and the trauma that he or she goes through again have to go through the similar way. So child-friendly environment in the special courts have been done, and there are a lot of other initiatives which are being taken. Especially, we also have the aftercare provision, where children who crosses the age of 18, but still they don't have anyone, or their restoration was not possible, and they cannot live in the children home anymore. So those children are being provided financial support from the government side, and that program is called the aftercare program. Similarly, we have sponsorship program where we try to help the child through giving financial support. So these steps are being in place, and and as we all are aware that the government has been very, very strict on child marriage, and a lot of arrest has also been done, but the rehabilitation part and the restoration part is the most challenging part. And as a society, as a conscious citizen of this country, we should come together in creating more awareness and having more, intervention in this kind of arrangement where the society will be. We should try to make the society to bring in such a way so that this kind of victims are not treated as, guilt or as accused person. They are more they are more involved in the society. And I feel that while dealing with children, as the earlier speaker had, respected speaker had talked about, that it is, they don't require, and we are, as we, all of us are not psychologists. So I always feel that, the counseling part will be done, we should be done by the concerned, trained person. And we, while dealing, we as stakeholders who are associated with children, we should look at the children with more empathy. So it's not sympathy, it's empathy that will try to help, because while dealing with child, we have to connect with the child. We have to understand his or her environment. As a doctor, as a citizen of this country, or as a government servant, or any of the stakeholders, we need to have empathy when we look at the child. And I'm sure that in the future days, even if one child also we can help, and in bringing a victim, we can help him or her, bringing back and streamlining their life so that they can also become a good citizen of this country and contribute to the society. I think we have will be successful. And we have got a good opportunity of in this way of to work for child who are the next future of this country. And the government is striving hard for protection and prevention of the children. The protection mechanism, as I have just discussed, is all in place. And I just want to also mention one thing, that the special police juvenile units are in place in all the police headquarters. We are trying to make the police PS also child friendly. The GPUs are basically working for the child trafficking cases. The anti-human trafficking unit is also there, which is also working together in close collaboration with the District Child Protection Society units, and that's how we are moving. So the overall emphasis is care, protection, rehabilitation, restoration, and mainstreaming to the society. And these are the some areas where we get challenges. And one type of challenges we again receive from the repeated offenders. So there, I think the counseling part is very necessary. And here the respected participants and the speakers who are there can help, I think, in this aspect, where counseling, what type of counseling, and which is more suitable for a
Thank
children.
you, ma'am, so much.
And with this, I think I have covered what the topic that was given to me. I again congratulate and thank AIIMS for giving me this opportunity to share the views on this. And with this, I thank you all, and thank you, Dr. Nilanjana, and thank you all for the patience hearing. And
Thank you, ma'am.
Quite cooperation and building up in such a society where we know we can say that
yes,
our
ma'am.
children are protected.
Ma'am,
Yeah.
thank you,
so
ma'am.
much.
Despite your busy time, you gave us so much time, and it was really very nice and helpful to actually know what is going on in the government sector. We look forward to some more collaborations with you in days ahead, if it is possible. So we look forward to have some projects with you and some collaborations to actually work at the field level with your help and with your expert guidance. 10 minutes is very less for you. We just felt that we keep on hearing you. But
Thank you
ma'am,
so
this
much.
very
Thank you so
but
much.
I
And I
look
would
forward to have some.
permission to leave the
Yeah.
space. And I
Sure.
look
We'll have
forward, but
some.
I'm sure that we'll meet having
We'll
a
collaborate more. Yeah.
seminars.
Surely.
Yeah. Thank you so much.
Thank you so much, ma'am. Thank you so much. With this, I request our next speaker, Dr. Raman Kumar sir to please share his expert opinion and guidance for the same, for the webinar. Thank you, sir. We had to keep you waiting and we had not shared the last link. We're very sorry for that. But sir, please, but despite your busy time, you're always there with us. And he is a pioneer in family medicine. He is a great inspiration to me in person. I remember telling sir once during my PG days, sir, what to do, and sir gave me directions from then on. Sir is a big inspiration to all of us. Sir, please enlighten our audience with your expertise.
Namaste to all of you, and thank you very much, Dr. Nilanjana, and all organizers, ClearNet, AIIMS Guwahati, Department of Community Medicine and Family Medicine. It is indeed very heartening to see that such a session has been organized, which is very pertinent to today's time. And as a family physician, I practice in community. I practice in the suburbs of Delhi NCR, in an area called Noida Extension, and we have high-rise society where we have middle class, high middle income families living. And this process is happening across India. We have metropolitan cities and smaller cities are also developing. So society time is also changing. Economically, we have a very big middle class. So traditional discussion on child abuse, we heard today from the perspective of experts from different stakeholders' point of view. But family physician's role is the physician in community. So I will partially share my own experience and partially also in a form of how family physician can act as safety net towards prevention or saving children who are in the situation of child abuse. And we have heard what is the definition of child abuse, what are the types of child abuse. So I will not go into that detail. I want to start with discussing the context and the locality. Context is the community. And when we talk of community, we all know about the tip of iceberg phenomena. So every child that is brought to or presents to institutional care, like hospital or police station or judiciary or a juvenile center, there is a iceberg phenomena to this, and there are thousands and thousands of other children who are in the situation of abuse and who are not recognized through the institutional process. So of course, when we talk about law, when we talk of hospital care, when we talk of medical care, we are largely covering the children who are in the upper part, who are the visible part of the abuse morbidity which is prevalent in the community, in the society. So as family physician, we are used to saying normal patients. Many of the times, often families visit with their children, parents come with the children, children come with their parents. So all these situations gives us and puts us in a special interface where we are seeing a lot of normal families. They are not in situation of any acute care requirement. They often come for small problems like cough, cold, hypertension, thyroid, common things. And what is our observation in that situation, I would like to share. So we talked about actual abuse signs, hidden signs, symptoms of abuse, physical abuse, for example, are different. But what I want to emphasize is the common things, like even a case of dog bite, whether it is a at home animal injury or at outside peri where habitat or around the area where the children play, go out or walk or stroll in that area, even if they have dog bite or injury. So injury is the common problem with the parents bring children to the family physicians. So why does this injury take place? Often this is because of neglect, because children are not developed enough, not mindful of what the risk might be there in dealing with the environment within home and outside home. So they are always at risk within home for injury, in kitchen, in bathroom, in drawing rooms, in situations of falls, in situations of crush of finger, cut, electricity, all these things, situations, we have to make our home safe So if we are not making our homes and surroundings safe, that is the first, we are, we are exposing them to, all kind of physical abuse, which is, injury. So it is not just, intentional injury that happens, but unintentional injuries that may happen in home and outside home is also a kind of, I would consider an abuse. And nowadays, time is very important because we see people, as I said, society is changing. So we are living in nuclear families, and often the support of the joint family is not there. So in the joint family days, we used to leave our children with the other family members. They used to be safe. They were protected by their siblings, extended siblings, chacha, tau, mama, masi, all these kind of situations. They were, left safe. And but that system of our families is shrinking, and we are left with, with more of many times single parents, also many times, nuclear families where there is very little time for children. So child rearing also requires time. And the newer trends that you see, that children are often left with unattended, with laptops, mobile phones, earlier with TV, and this kind of, not giving enough time to children is also kind of abuse, I would say. It is unintentional. Many times it is not avoidable, but leaving a child with mobile phone just for playing, and I've seen, in very early childhood nowadays at my clinic, while, the parents are coming for consultation, they have given children their mobile phones to watch cartoons, or even if they want to please their children to have food, they will encourage them to watch mobile phones, and, things that is normally, this not used to be the case of the previous generation. So the time is entirely changed. So when they are exposed to internet, the internet, even for adults, it is very toxic. If you watch the reels, the types of reels, it is very toxic environment that we are living in a digital world. It is very difficult for even adults to keep their mind aligned to a neutral position, moving forward with sanity. It is difficult for children to decide what content is right for them and what content is not right for them. There is a system of supervision inbuilt with all IT digital systems, but we often do not take care of that. And many times children would be exposed to unintentional content which is not good for their age, and they are not also good for any age, actually. So digital toxicity, is very, very important these days in respect to child care, child abuse, and we should be mindful of those things. I'm talking from the perspective of families that come to us, that we see in a day-to-day practice that is happening. Another form of abuse that we observe is with respect to food, because, our food pattern is also changing, and there is, conventionally we all used to cook in our own kitchen and have food together, and children would learn feeding practices at their home. But these days they are learning their food practices is also coming from outside peer groups and their schools, and also within homes. Many people are feeding their children things which are not common there, which are not health friendly, fast foods, chips, kurkure kind of things, and chocolates, overfeeding with things which are not nutritious, actually harmful. Many times they are not medically even certified in terms of, food value. They are being fed to the children just for the sake of, taste, or just pleasing them, or, trying to overcome their tantrums or things like that. So food, giving them not right food and nutrition. One part was earlier when, somebody was not given enough food or enough of calorie or protein. We used to talk about protein, calorie malnutrition. But this kind of, overfeeding, feeding wrong things, feeding things outside, food delivery is very common these days. And many couple who are working, many times they are entirely dependent. These days, I see many families which are entirely dependent on, outside cooked food, and home delivery of food is very, very popular. In such situations, we are also not only making mistakes for ourselves as adults, which is leading to unhealthy trends, but also making food choices for our children. We are exposing them to foods that is not healthy for them. So all these things are new trends in my understanding in child abuse. And we should be mindful when we are talking about, and this is also tip of the iceberg, as I said, part of the abuse process. And we have to be mindful and also try to address these things in an institutional way, at least in the academic way, that we have to articulate that these are also problems which are, happening in our society, and this is how our society is evolving, developing. It is a dynamic situation. It is, evolving, and we have to be very, very sensitive about such situations. And then in nuclear families, we again have, domestic violence, intimate partner violence, these situations where, parents are not talking to each other, children are living on their own. This is again a form of neglect, which we should, as family physician, these come to us, and they are very subtle symptoms where we have to find, and often these things do not present directly, but when we are examining or interviewing children or their families, we can sense that there is something wrong uh, with this family, with this child, with this parent, with this, partner, and we have to identify those things. Most of the times in our practice, we do not see patients or children or families which immediately required police care. I mean, in policing, in sense of, law and legality, because largely these are social level of neglect which cannot even be defined or articulated in a breach of law. But these are also, areas where we have to act and work and counsel the family, or, anchor the family in a way that they are uh, able to modify their lifestyle for the benefit of the children and overall safety. So we have to extend safety net in a comprehensive way, in 360 manner, where we have support of all stakeholders. When we talk of law and legality, it is a very, very part of a very fraction of our society, because Indian society is not largely dependent on government. Government has a very partial role in defining the lifestyle, culture, popular choices of the families and the people. It is unlike the Western societies in Europe or America, or very structured society where everything is dependent on state policies. People in India is an open culture, and we have largely societies living independently of the government policies. So it is a situation where, law enforcement will come rarely into picture, and we have to be mindful when this has to be, intervention level. And practically most of the time it would be socio, psychological, partially medical things that we see in our society as physicians, that what we can do. And potentially, because, family physicians are part of the society, they're also considered part of the extended families. They give advice, and people listen to the advice of their family physicians also. And many times, women come to us and say that, you please, tell my husband not to smoke, not to drink at home, not to bring, sleep at late nights and things like that, because they understand that, once it is doctor gives advice, my family member or my partner would understand or listen to this kind of things. They also come to us and say that, sir, please advise my daughter not to behave like this, not to, eat food like this, and try to eat good food, or, healthy food, or don't eat for outside. So because they know that the family members many times do not listen to each other, but they listen to their personal physicians who are. So family physicians role is very trustworthy in society. Their role is more, powerful than police inspector, because we do not go to police stations. We go in a in a situation where actually there is a physical breach. But in normal situations, family physician's role as a counselor is very, very important. So it is important that as family physician, we train ourselves with the legalities, with counseling skills. Of course, we have medical skills, but these all should come together. And often this traverses across all age groups. So it is not just about counseling the children, but it is also counseling the parents, the extended family, and the society in the community. A lot of dog bite cases we see, it is all because of the society's neglect at large. And largely we see the age group of the children who are the victims of this situation. Why a stray dog should bite a child on the street, and how we can make our communities safer. We have families which are shrinking, but where do our children go? They go in school buses, they go to schools, they go to parks, they go to play, they go for tuitions. All these places should be safe for them. And they go to clinics, they go to hospitals, they go to all kind of institutional situations like hostels. And all these situations should be safe for the children point of view, from all four domains of physical abuse, mental abuse, emotional abuse, sexual abuse, and neglect. So getting right food in hostel is very important. Right emotional support in hostel is very important. So be it hostel or home, every place should be safe from all domains perspective. And we should try to uh, capacity build our family physicians, and family physicians have capacity to build the capacity of the community in sense of the community leaders, family members, all across age groups, teenagers, even elderly people come and ask us for our advice for their, family situations. So this is the role of family physicians, primary healthcare physicians in the context of child healthcare. I've tried to bring it to more contemporary things that we are observing. And of course, the institutional things have been discussed, and we need an integrated interface, which is, provides a larger safety net for our children of our country. Thank you all. Thank you for this opportunity. Thank you very much.
Thank you, sir, for the wonderful presentation and your time and just the crisp and the essence of it. We look forward to having some more projects which directly relates to the cause with family healthcare physicians, and we will look forward to having more sessions with you, sir. With this, we hand over our the next session to Professor Dr. Gunojit sir, who is the head of the department in forensic medicine in Dhubri Medical College. Dr. Subhrajit can take over. Dr. Subhrajit?
Yes, ma'am.
Please take over. Please introduce Gunojit sir, and he can carry on with the presentation.
Welcome, sir. It's a privilege to introduce Dr. Gunajit Das, Medical Superintendent, Dhubri Medical College, and Professor, Department of Forensic Medicine and Toxicology, Dhubri Medical College. Sir, I would request you to kindly begin with your presentation. And sir, with that, I would also request you to be a part of our panel discussion, which will be starting soon.
Okay, good morning, everyone. Am I
Good
audible?
morning. Yes, sir.
Okay. I have 3 or 4 slides. Can I share that?
Surely, sir.
My sincere thanks to the organizer for giving me this opportunity to be on this prestigious platform today, where the things are discussed in a very elaborate way, and I'm very much privileged to know from the esteemed speakers also, because it is always a two-way process of learning in such kind of gathering. Coming to the topic, actually, I'm just given a small topic on this. My topic is restricted to the child sexual abuse, in what way we receive them, in what way we have to deal with them. Now, being in a medical college or in a health establishment, or any health setup, there is every possibility of getting such cases where there will be history of sexual assault, and sometimes there may not be anything, but this may come later on our association with the patient during the treatment process. Now, for us, whoever arrives in the casualty or in any hospital, he is first of all is a patient, and taking that particular individual or the child as a patient, our first and foremost duty is to provide treatment. Now, the thing is, whenever we say something about child sexual abuse, there is a different way of presentation at times. From my personal experience, what I can say is we may receive in two different ways. One is those may be brought by the law enforcing agencies, or the cases or the patients may, I'm just referring them as patient because I'm coming to that later on as the survivor, and the patient may come voluntarily. Now, when they are brought, it's not moving actually. Okay. So on requisition by law enforcing agency, there will be a requisition letter and there will be identification details, the accompanying police personnel, and everything will be there, wanting us to determine whether there is signs of any sexual assault or abuse. Sometimes age is also asked, but usually it is not asked because the POCSO Act that does not mandate if there is any proper document of the age. And also we are asked to find out whether there is any violence on the body, and subsequently some report is asked, and we prepare on the basis of the findings that we get during our examination. And the other way in which we can get the cases, that is a voluntary. Sometimes the guardian may bring a child, or sometimes the child, if she is of the age of say 14, 15 or 16 or 17 like that, she may come directly to the casualty and say something else not related with the sexual abuse. But during the examination process, it may come to the mind of the examining doctor that there might be something related with sexual abuse, and careful history taking reveals it. And then comes the mandate of section 19 of POCSO or section 357C of CRPC. We are just omitting that 357C as we are restricting our talk to the children only. So sometimes these voluntary patients which come, or the patients who come voluntarily to the casualty, they know about legal provisions which can be there, and sometimes they do not know. But whatever may be the condition, as it is mandated under section 19 of POCSO, we are supposed to intimate the police or the local juvenile police unit or the local police. Now, the first hassle comes right at this moment, because there is nothing that the medical officer who will be intimating the police authority should take a consent of the guardian or something like that. No provision is there. Even if there is an apprehension in the minds of the particular treating physician or the person, he is supposed to intimate, because there is a provision of even punishment if he fails to do so under section 21 of POCSO Act of 6 months to 1 year of imprisonment. Now, coming to the actual examination process. Now, the problem is there is no dearth of guidelines regarding the examination of sexual abuse in case of a child, but practical scenario sometimes becomes totally different from what is actually described in all those guidelines. The primary guideline that we have is the guideline issued by the Ministry of Health and Family Welfare, and on the basis of that, some NGOs which are doing tremendous job in this particular issue have come up with some simplified guidelines so that everyone can understand. Even they have simplified the legal language also, and it becomes very easier. One of them is SEHA, and which has come up with a very comprehensive guideline where I have taken a flow chart. They have given a flow chart of examination and the process in which we should proceed. Now, the first thing that comes into consent. Now, the problem is if we start the examination immediately, it's not like that. Examining it, because there is chance of, personally, I have experienced children of age even 4, and then a child of age say 17, even 17 and a half. Now, if our approach becomes uniform for a child who is 4 years old and a child who is 17 years old, the process is going to fail. Because my approach should be somewhat different when I shall be dealing with a particular child of 4 years or 5 years. I have to bring that comfort to the minds of the child. And she should become very comfortable in the environment where she is going to be asked certain questions, not in the form of direct questions, but in a conversation, or bringing a proper conversation between her in presence of her presence or the person with whom she is more comfortable. And that may not be required to that extent with a child who is say 16 years old or 15 years old. And that becomes an art for the particular medical officer who will be dealing with that, keeping in mind that many times we see this as a burden in the minds of the doctor, but that should not be. It should be taken as a part of our profession, part of my duty when I am on duty in the casualty or in the say emergency. And that time, it is somewhat time consuming, and that time should be devoted to the particular cause, so that the child comes to a point where she feels comfortable and she reveals what actually has happened with her. And it becomes very difficult with a age group between say 4 years, 5 years, 6 years, 7 years or so. And that's why the patience is what is required at the beginning of the process. And ultimately, once we get the consent of the guardian, or if she is say above 12 years, that will be governed by the particular law. And after that, the first and foremost thing is to give first aid. Because for us right at that moment, she is a patient, and we have to see whether she can sustain that particular period for taking history or something like that. My first aim is to stabilize the patient and give first aid, so that we can go for further treatment. Now, coming after that, once he is stabilized, we have to go for taking the history regarding the entire incident in a very calm and quiet manner. Once the history is done, we have to proceed with the examination. In the process, we have different protocols. I'm not going deep into it because it should be question answer based. In the panel discussion, definitely it will come up. And once it is done, during the examination, if there is a need of age estimation, definitely the physical, dental, and radiological investigations will be required. Thereafter, the evidence collection. Once all the required evidences are collected, that should be packed, sealed, and along with that, with documentation, it should be handed over to the police. And if treatment is required, we have to specify our points towards the treatment of the injuries. If she has sustained something, sexually transmitted infection test and prophylaxis if required, then HIV test with proper counseling, and then subsequently prophylaxis if required. Emergency contraception is another point. Then urine pregnancy test if applicable, and counseling of the particular patient. Subsequently, on certain occasions, there may be requirement of further treatment to the patient by some other specialist. That referral services should be there. And then discharge of the patient and subsequent follow-up. But it doesn't end there. Definitely, there is a question of reporting. In the reporting, these are the 4 points. There is some numbering problem. First one is the injuries. Then in details, whatever we find at the time of examination, that should be recorded properly. And all those genital injuries to justify whether they are suggestive of attempted or committed sexual assault or abuse, all the perineum, vulva, hymen, vagina, cervix, uterus, and all other 4 points which are there in the section 4. Then laboratory tests which may include presence or absence of spermatozoa is as and when required. It may not be required in most of the cases. And if we preserve many of the samples for examination by the forensic science laboratory, and on arrival of or receiving those laboratory reports, subsequently a proper report should be prepared so that it helps the law enforcing agencies in apprehending the perpetrators and the judicial authorities in deciding the quantum of punishment. So the entire process needs some amount of patience and a good setup where the child gets proper care as well as proper environment to express. And there should not be any fear psychosis that she is brought to a hospital. Because in most of the children, whenever we find they are apprehensive of any medical procedure, and that's why a proper conversation is the most need of the hour when they are brought or say brought by guardian or they appear. Sometimes few instances are there where they come, like say one incident when which I can remember. With that, I'm just going to conclude it because I have already crossed 11 minutes. The patient was brought by, the particular child was brought by the parents with history of diarrhea and vomiting. And later on, because it was a pediatric case and with that history, definitely the idea goes towards a acute gastroenteritis. The treatment was started. There was no intimation, nothing about sexual abuse or something like that. And later on, she was vomiting very frequently. And later on, when it was not subsiding with treatment, she was sent for ultrasonography and it revealed pregnancy. Now, when it came to the knowledge of the parents, somehow they absconded the hospital, and when it was searched in the hospital repository regarding the address and all those were fake. So there is, because of social stigma and all these things also come on time. Each case is to be decided on its own merit, and decisions should be taken right at that moment by the particular doctor or the hospital authority, and that may not go as per the guidelines which are being issued by statutory authorities. And whatever decision is to be taken, that should also be within the legal framework. So there needs to be a regular exercise of discussion regarding different cases that we receive on a monthly basis or weekly basis, so that we can come up with certain cases which do not conform with the particular guidelines which are being issued, which are being distributed, which are being read by many of the people. With this, I just conclude, and I hope we can create that environment also. Thanks to the organizers.
Thank you, sir, for the nice presentation and very apt and very much in place. We look forward to have more sessions with you, and we would really thank you for your time. With this, we move on to our next speaker, Dr. Pranjal De, for his deliberation. Dr. Subhrajit, please coordinate. Dr. Pranjal De, Dr. Pranjal De for the next deliberation. And after that, we will have panel discussion with Dr. Sharan Malia and Chandana Bhuiya ma'am, which Dr. Subhrajit will coordinate. So, Doctor, thank you, sir, once again. And Dr. Subhrajit, Dr. Pranjal De, sir, are you there? Dr. Pranjal De, please connect for the next session. Dr. Samarande, sir, are you there? Please connect.
Dr. Pranjal.
Dr. Samarande, sir, are you there? Dr. Samarendra, sir, I'll just call him. Just hello. We can start off with the panel discussion. Dr. Subhrajit, please take over the panel discussion. We can have the presentation of Dr. Pranjal Das after this. Then Dr. Sharan Malia and Dr. Chandana Bhuiya ma'am will be in panel discussion. Dr. Subhrajit is moderating the entire session. Thank you so much. Dr. Subhrajit, please take over.
Okay. A very warm, good, it's almost afternoon. I would say a very warm, good afternoon. I would like to welcome our eminent panelists. First, I would like to welcome Madam Chandana Bhuiya. She is Madam Chandana Bhuiya. Is she there? Yes. Madam Chandana Bhaiya is a consultant psychologist and an internationally accredited psychotherapist, currently affiliated with Pratiksha Hospitals. She is a life member of Indian National Council for Child Abuse, Neglect and Child Labor. Then I would like to welcome our next panelist, Dr. Sharan. Dr. Sharan Malia is an assistant professor in our institute, AIIMS Guwahati, in the Department of Orthopedics. He has multiple publications in index journals and one patent application in India Patent Office. He has been involved in treating pediatric and adult trauma cases. Next, I would also like to invite Dr. Gunajit Das to our panel discussion. As Madam has already said, he is the medical superintendent, Dhubri Medical College, and also professor, Department of Forensic Medicine and Toxicology, Dhubri Medical College. With it's a matter of great pleasure and pride that I have been given this opportunity by my institute and Dr. Nilanjana to moderate this session. I would like to first begin our round of questioning. Actually, we'll have to limit the number of questions because we are already running a little late. Sorry for that. So our first question would be to Dr. Sharan Malia, sir. What are the various red flags that you have observed in your daily practice that raises the suspicion of possible child abuse? Sir, if you could please take over.
Good morning.
Sir, it's muted, sir, your voice.
So please switch on the audio part of the Zoom.
Yes, sir. Sir, if you could start.
Yeah.
Sir, should I repeat my question?
No, that's okay. You can hear me, right?
Yes, sir. You're audible.
Yeah. So actually, yes, we have started our OPD services and all. So we are getting cases, and most of the time, like what I have noted, like the kids will be brought by some guardian or their parents itself, and like the history what they give, and then the examination what that will not be correlating. I mean, sometimes they will like there was one case which I would like to mention that 9-year-old girl was brought to the OPD, and the history was 2 months back there was a this thing, she had a fall, and there was a fracture in the leg, and the fracture had united with the with the deformity. So I happened to ask them, like 2 months back injury was there, have you did you go to any doctor? And they said no. Like for 2 months there was no treatment given, and now they are brought. And then they asked where are the parents? So the child was from the foster home, foster care. So the guardian says that we didn't know what to do. So like I was going through the this presentation, Dr. Summer had mentioned that there was a there are different kind of child abuse, like physical, sexual, and this was a neglect. Here for 2 months the treatment was not given. So here the challenges for us, like I mean, these are some of the red flags. I mean, we have to report this. So the next thing was to report it, making it an MLC, because there was a neglect in this case. So these are the one, and the other things are sometimes what happens is the history what given and examination also is correct, but there will be suspicion because now we are having one case in our IPD which like the child 3 times he had fracture in the same forearm, and he was treated with surgeries. Thrice he was and same forearm with three times he had this thing, and this is the 3rd time which is happening. So like there is a suspicion for me, like why in the same forearm 3 times he is getting injured. Like these are some of the suspicion, but whether to report or not, when we ask them, even the child says I had a fall, and even the guardian says I had a fall, but whether to report these cases based on the suspicion, because 3 times injury in the same forearm, it may be coincidence, but like 3 times. So these are the challenges, like some suspicions will be there. So whether to report these cases or not, that is also one thing. So So these are the few things which I have come across, and there are other cases also, but so these are the things which I want to put across.
Thank you, sir, for the very lucid and crisp answer. Next, I would like to move on to Chandana, madam. Madam, my question to you would be, what are the behavioral changes and features that can be seen in a victim of child abuse, both the long-term and short-term, if you could slightly elaborate on it?
Thank you so much for the question. Usually what we see in a short term, in an acute manner, is a sudden change of behavior. So there could be anger issues and withdrawal, insomnia. These are very common usually symptoms that we see. And other than that, we can also see all of a sudden pain issues, unexplained pain issues, which are somatic in nature. And also one thing I would like to point out, there are a lot of idiopathic urticaria or idiopathic allergic issues, which can be also seen, in cases of psychological abuse. So the problem is that if there is some kind of physical abuse or sexual abuse, you can at least, find out there is a scan or there is some kind of, way, tangible way to find it out. But in case of psychological abuse, in case of a child, it's very difficult to screen, but we can see in the behavioral changes. So if there is sudden behavioral changes, definitely it is a alarm, it is a red flag, and the doctors, the physicians, and the teachers, they are the frontliners actually to identify this kind of cases, and because we don't have the first line access, so they should be actually reported or at least referred to a psychologist for that. I would also like to say, like, many times, I mean, we have been in my practice, at least I'm seeing that lot of panic attacks, they are given anxiety medication. But if you go for detailed history, you would know that there is a lot of, natal family abuse was happening, or probably the child is witnessing a lot of domestic violence and the child is not allowed to talk about it. And that can be also seen as, some kind of psychological issues. So these are the very common symptoms that I have been observing.
Thank you, madam. Thank you, madam.
And in the second part of your question, what are the long-term consequences? So there is a study, I think all of you know about the effect of adverse childhood experiences. So we have a definite tool to screen if there is 4 or more than 4 different kinds of adverse childhood experiences in a child. That child is going to experience different kind of cardiovascular diseases, including cancer and depression, suicidal ideation. All this probability gets increased by more than 12%, in some cases more than 37% when they become an adult. So I also see patients who are coming to me for their acute suicidal ideation or probably chronic depression. What I can see, actually, there are unaddressed childhood trauma in their life, and which has not been processed or addressed, and that has been, showing up in a form of a disease, unexplained disease, so in a somatic manner, or some form of psychological illness.
Thank you, madam. Thank you, madam, for
Ma'am,
elaborating.
I have a question. I have a question to ma'am.
Yeah.
Ma'am, are there some
Yes, ma'am.
red flag signs to understand, like the child is going through a problem, the red flag signs can be told? How will a patient
Yeah.
understand?
So,
What's the red flag?
ma'am, yes, ma'am, this is a very good question, because if the parents are aware, conscious parents, and they take care of the child, in that case, the parent will notice and they will bring the child to you. But it's very difficult to understand if there is natal family violence is involved. So in that case, what we can observe, the child comes to the school early or probably doesn't want to leave the school. The child, likes to, stay outside the home more. Those are few very subtle manner, and there are consistent unexplained physical issues, like, gut issues, mostly gut issues, eating disorders. These are red flags. These are definitely red flags, so we should be considered to that.
Thank you. Dr. Subhrajit, please.
Thank you, madam. Next, I would like to ask a question to Dr. Gunajit, sir. Sir, if you could please unmute yourself. Sir, the question is, suppose a case comes to us from some other department, like suppose a case has been referred to the Department of Forensic or has come to the Department of Community and Family Medicine from suppose pediatrics or orthopedics. They have suspected a child abuse case, flagged it and sent to us. What should be our next approach, sir?
Now, Section 19, if I go to the particular section of the APC, POCSO Act, Section 19 POCSO specifically mentioned about even the apprehension. So the first one, or the first doctor who comes to the knowledge or comes to have the knowledge or apprehension that there is a question of child sexual abuse, so he is mandatorily bound by Section 19 to intimate police at that moment of time. Now, here, if the patient is in pediatrics, that means the stabilization part, the treatment part, that has been established. We are not supposed to go and give treatment to the child right at that moment. That part is already established. Now, two questions may be there. One is whether the child was actually brought by police right into that particular department, pediatric surgery, medicine, or whatever, or this particular thing is disclosed now only, and the patient have been undergoing or doesn't have been undergoing treatment in that particular hospital. Okay. Now, whatever may be the scenario, if the patient is brought by police, the police information part is over, and automatically the police will come to the forensic medicine department also. And evidence collection and all other things can be done by forensic medicine people, provided there is female doctor or lady doctor, because in the state of Assam, it is mandatory also. POCSO mandates it for a female doctor who will examine. Now, the point at which, say, being a forensic medicine personnel in the Department of Forensic Medicine, I receive information from pediatrics department that I am called to go and examine a case. The first thing I shall inquire whether police intimation is given or not. If it is not given, it should be given because the stabilization part is over. And it is not my responsibility right at that moment. But if it is not done, it should be done immediately. And by that particular doctor who came to the knowledge of having that incident. And thereafter, once that part is over, the evidence collection should be started, the examination can be done, provided we have the female doctor in the forensic medicine department or a specialist. If it is not there, even the registered medical practitioner can also go with the particular protocol. And I already have given that the proper examination should be there in a proper setup. The child should be given that comfort so that she discloses properly, depending on the age type. Our conversation should be like that, whether she belongs to a particular age group of, say, below 10 years or below 5 years, or say 15 years or 16 years, like that, so that we can extract as much information as we can, which will help even the investigating agencies. As Sandana madam has already told, that there needs to be a proper counseling also, proper psychological assessment also, so that we can come up with all the informations that are required for establishing the particular crime. And there should not be any confrontation. What I suggest, a very pertinent thing that I have done in my hospital, being the superintendent, that we have come up with a very proper way of dealing with it, having a standing response committee where I have kept people from all departments, one particular single point contact person from all departments. Say in pediatrics, if they need surgical consultation, they can connect that particular person in surgery. He may not be on duty, but it will be his responsibility to coordinate so that proper surgical care can be given. Same is the case with forensic medicine. It is not that just by writing a call letter, the responsibility of the pediatrics department will be over. They can contact that particular one-point contact person for dealing with such cases, and all these people can get together and examine. It is not that the patient will be brought, the particular concerned doctor has to go. There should be a proper comfort given to the particular child. That's what is my submission.
Okay, sir. Thank you. Thank you for elaborating so much. Thank you for clearing so much of doubts. There are so many more questions that I would like to ask, but since we are already very late on schedule and a lot of our speakers have been waiting, I would just like to sum it up by saying that
I'm just, Dr. Shubham, just one question, Dr. Sharan sir, I just want to ask one question. If any case, such case comes to OPD, in ortho OPD, what is the protocol like? How do we manage? Or what do you do? Like, do you, like, as of now, so that we can, work on it later?
Dr. Sharan.
Uh, okay.
Could you please repeat the question, madam?
So suppose any such case comes to ortho OPD as of now, then what is the next protocol we can do? Can we keep the child admitted? Because if the like you're saying recurrent trauma, so every time the child goes back home, the trauma will be increased. So we keep the child admitted and then report to the police or maybe some appropriate authority or CWC. So does the role of do you report to CWC from OPD? That is one question we have.
Yeah, that is one of the challenges we are having, madam. Like, see, there is a suspicion that it may be a child abuse, but now the next point is we should have a committee or a panel, like who will discuss it first and then take it towards like filing a medico legal case. I think it is better to have a panel or the same internal hospital panel or a committee which will discuss this and then take it forward. I think we should do that. And for suspicion cases, I think we should have one objective questionnaire or a scoring tab, like for the doctor himself, to identify these cases, like whether it is qualifies to be reported. Means, like you have a suspicion, but it may not be. There may not be any foul play in that. So that's why we should have one objective questionnaire for a clinician himself, whether to report. And I think creating a committee or a panel would be good in this case.
Okay, sir. Okay, sir. Thank you, sir. Over to Dr. Subhrajit.
Okay, ma'am. Like, if there is no more question, then, ma'am, can we move on to the next session?
Yeah. Dr.
Thank you, Dr. Gunajit, Dr. Sharan, Chandana madam, everyone for your detailed input, for the insight that we have got. We have learned so much new things. We have learned about the protocols, how we can design protocols for better management of such cases. We have learned how, like, it's not about just about the acts of commissions, rather also more about the acts of omissions such as negligence. It is such a pertinent thing. I would now request Dr. Pranjal, Assistant Professor, Department of Psychiatry, AIIMS Guwahati, to take over, please. Pranjal sir, if you're there. Pranjal sir, am I audible?
Welcome, sir.
Yeah. Thank you, Subhrajit. Good afternoon, all. My topic today will be psychosocial approach to the victim of child sexual abuse. And I will just highlight this points and important aspect of this topic. To change, yes. And the intervention will be of in three aspects. The psychosocial intervention. The first will be the first level response for the children, where we should not give the in-depth intervention or in-depth question. We should not ask. Next is the in-depth intervention, and third is the intervention for the parents and the caregivers and family members. Move to the next slide. First of all, the medical assistance is very necessary. We should complete all the medical examination and this medical treatment, like any for medicine, surgery, or gynecological aspect. Then our psychosocial intervention and mental intervention comes for the patients and for the family also. Next slide. And then the first level psychosocial response for the children will be, first of all, one of the most important thing is we should not ask about the event or what has happened to the child. It should not be asked at the very first instance. And second one important, if there is any psychiatric symptoms like which is not manageable, then proper psychiatric referral should be done immediately. Then the first level response will be of supportiveness. We should be the caregivers, family members, neighbors, or should be supportive to the victim. Next is the rest and recreation for the victim from recover from the traumatic event. Like she should be encouraged to play, listen to music, and do her day-to-day like activities. The main aim is to keep her or him occupied with the things. so that she cannot recall, she should not have the time enough to recall these events on repetition that what has happened to her. Then the parents, another important thing is the parents and caregivers should give a quality time with the children. But that time, giving this quality time, they should not ask about that what has happened. They should not try to extract the details of the event from the child. Next is the another thing is relaxation exercise is very important for the victim. There are different types of relaxation exercise. One is deep breathing exercise. Another is progressive muscle relaxation. Another is guided imagery. So these things, I think in question answer part, this psychologist man has already been already explained. So this helps in keeping the child relaxed, and their anxiety provoking thoughts does not come on repeatedly. Then she should resume her daily routine, like going to school, going for play with her friends, going to relatives' house. It should be resumed as soon as possible. It should not be delayed. And these things helps in reducing the anxiety, and the family members also and the victim also, they have the very less time to think about the abuse event. How much they will think about the abuse event, so much they will be become pathological mentally. Now second part is the psychoeducation and support for the parents and the caregiver. This is very important, because here we do the mistakes mainly. So they have to accept that what has happened to her child. They should accept that. They should not accuse her that why you have gone there, why you have not informed us while going outside, why you have mix up with it. These things should not be done on the initial part. And they should understand that how the abuse has happened, how the abuse dynamic, they should understand. Now some few signs, symptoms they should know about their mental state, like some symptoms of anxiety, depression, then post-traumatic stress disorder. Sometimes patient may become very restless. Sometimes patient may become very withdrawn from the daily activities. Sometimes maybe very become low. These are the common symptoms. Sometimes they are very aggressive or irritable. These things are also happening. So then the parents should be very much supportive, and reassurance should be given to the children. And a few red flags are there, like when the child is very in extreme distress, extreme anxiety, sometimes they may have suicidal or some self-harm behavior. This should be kept in mind, that if it is there, they should do immediate referral to a psychiatrist. Then the parents should engage the child in developmentally appropriate activities, like proper meal time, play time, bedtime. These school routines should be resumed. Another important aspect, which is very important, is if there is any sexual abuse in an adolescent girl, then the questions of pregnancy comes. Though here the decision should not be taken alone by the parents only. The child's thought and their perspective about the pregnancy should be taken. They should explain what will be happen if the pregnancy is continued. Then the decision should be taken by the child along with the help of her parents. But child's thought and perspective about the pregnancy should be taken always. If it is done only by the parents, then for in future, child may develop some psychopathology with these things. If there was a forced abortion and like this, then she may develop in later some psychopathology. Then regarding in our part, some drugs and pharmacotherapy, there is no specifically indicated pharmacotherapy for child sexual abuse. But if the patient is very much distressed, very much anxious and depression, then some benzodiazepines, these things can be given. If it is a long-term depression and anxiety, then some serotonin reuptake inhibitors plus short-term benzodiazepines can be given. But it should be assessed by a psychiatrist partly. And if there is a suicidal harm, dissociation, self-harm behavior, agitation, then proper management should be taken medically. Another most important thing is that some children have pre-existing vulnerability to some psychiatric illness. Maybe, for example, the child may have genetic loading of some mental illness. Suppose he has family history of mental illness from the either of her parents' side or like this. So she is genetically vulnerable. Genetic loading is there, but it is not expressed. With this child sexual abuse, definitely it is a trauma, it is a stress factor. Then there will be precipitation of this mental illness after this abuse. Like there's maybe mood disorder, mood dysregulation, schizophrenia. This should be kept in mind, and then the psychiatric referral should be done, and she should be kept on mood stabilizer. Mostly in mood stabilizer and antipsychotic. Otherwise, she may commit or may attempt suicide within a few weeks. These are the very important things we should keep in mind. And this is my presentation. Thank you.
Thank you, sir. Thank you, Pranjal sir, so much. And this is really about the most important part of the presentation, I feel, because this is a part which we all don't know, and we will look forward to your support always. It's really nice that we have you always and all your support, your patience, and the way you speak slowly. It went very well down with the layman as us also. We look forward to more projects, and we look forward to collaborate with you also, sir, with your presence. Thank you once again.
You're
Very
welcome.
much. Thank you, sir. Sorry for the delay. We couldn't accommodate the
No,
initial glitches were there. We're so sorry, sir.
no,
Thank you
some
really.
patience there.
Thank you so much, sir. Yes, I did realize, sir. Thank you, sir. Okay, sir. And with this, thank you, sir. With this, we come to the end of the presentation. And now I will now for the question answer sessions. If any question answers are there, we can take it up, or you can also inbox us directly. We'll get back to you on our emails. With this, I come to the vote of thanks for the session. Thank you so much. Thank you the institute for helping us. Thank you, Director Sir. Thank you, our HOD ma'am, Professor Dr. Purobi Fukan ma'am. Thank you to Kaustav sir, who is the additional professor and head of the Department of Forensic Medicine, who really helped us through all the procedures and silent planning. Thank you to all speakers, panelists, to Dr. Subhrajit, to Dr. Venkatesh, who is SR from AIIMS Patna and who gave the silent support. Thank you, ClearNet. Thank you to all participants also. And let us just fight for the cause, one for all for one. Community ownership is the answer to it. A child feels safe when he knows his parents are safe, and parents are safe when the neighbors are safe. When the neighbors are good, and they will lead out a helping hand. With this, let us pledge to end this menace. This cannot go on. Thank you so much once again. With this, I end the session. Thank you. We can leave if the session is over. We can all leave now. Thank you so much. Thank you, ClearNet, for all your support.
Thank you very much, ma'am, for sharing such valuable insights. And I hope you had a seamless experience. So we are looking forward to host you again very soon. And
Surely.
before we finally close, I would like to request everyone to have a shot.
Yeah. Please switch on your videos. Is it done?
And just a minute, ma'am.
Please share this with us.
Thank you, ma'am, for your time and effort.
Thank you. Please share the link.
Sure. Have a nice day.
Before we
Thank you so
disconnect,
much.
the question is coming repeatedly about the certificates. So how do we go about it? Like how will the speakers get their certificates?
Hello, is ClearNet there?
Yes, ma'am.
Yeah. So about the certificates, we want to ensure that please see to it that the speakers also get the certificates, and the facility and the participants also. Okay.
Sure, ma'am. I will be contacting the same message to Ms. Soma.
Yeah.
Thank you.
Okay. Thank you.